Caffeine is an absolutely fantastic drug, and I'm not just saying that because I love coffee so much. Hello and welcome to Tala Talks NICU, where we take medical concepts and make them super easy for you to understand. Today we are going to go over the second part of BPD. So if you haven't watched the first part, go back and watch that. Today we are going to be talking about 1, the prevention of BPD, 2, the treatment of BPD, and 3, outcomes of patients that have BPD. So before we continue, I'm going to ask you to like this video and to subscribe to the channel if you're interested in overall neonatal content. Right, let's start with number 1. How do we prevent BPD? So as I already said, hopefully everybody watching this video has already watched part 1, where we go over all the risk factors for BPD. So logically, if you decrease all the risk factors for BPD, then you will prevent BPD. So the most important effective way to prevent BPD is to prevent preterm birth. If in your unit there aren't any babies born below 28 weeks, then you've probably got a very low incidence of BPD in your unit. So do whatever you can to reduce preterm births. If you can figure out how to do that, that's fantastic. In the meantime, one of the most important things that you can do in the unit to prevent BPD is to decrease the amount of injury to the lungs. So the first way to decrease injury to the lungs is by giving babies as little pressure or volume support that they need that will still sustain them. So you are trying to reduce volutrauma and barotrauma. So put babies on the lowest amount of support that they may need, and then try to wean them aggressively if they seem weanable. Like we've said before, it would seem logical that babies that were put on high frequency ventilation, whether it's the jet or the oscillator, would have less barotrauma and volutrauma, and so you'd think that that would translate in studies to a lower risk of BPD. However, it's been really difficult to prove in these studies that putting preemies on high frequency ventilation categorically decreases the rate of BPD. And honestly, probably the reason for that is that there's so much practice variation between different practices, even probably between different providers, that even though theoretically it might provide a benefit, it's just been really difficult to prove in the literature. Where we stand now is that it is encouraged that the unit should get used to one device, whether it is the jet or the oscillator or even the conventional ventilator, and try to use it in an optimal way to reduce the volutrauma and the barotrauma for these babies. So basically giving the lowest amount of support, weaning aggressively, trying to get those endotracheal tubes out as soon as possible. So what about surfactant decreasing or preventing BPD? So when surfactant was first studied, what it was trying to prove was that it decreased RDS. And yes, the initial studies definitely showed that when you give surfactant, there is a reduction in RDS. And a Cochrane study in 1998 done showed that giving surfactant also decreased the rates of BPD, presumably by decreasing that aggressive initial RDS. So this is pretty much what we used to do with all micro preemies. If they were born, we used to intubate them and give them surfactant. Then in about 2010, the results of the support study were published, and the support trial compared giving CPAP to intubating babies and giving them surfactant. And it was found that the two groups didn't really differ that much in their rates of BPD. It was really this trial and a few other trials around it that really changed our delivery room management. And now we don't routinely intubate premature babies in the delivery room. Also, by extension, this also kind of shows that surfactant is not instrumental in decreasing the incidence of BPD. But as you all know, often these babies that are not intubated in the delivery room, so they're on CPAP and they come up to the unit, and very soon they've got very high FiO2 needs, or they've got a very high CO2, and they do need intubation. It's been shown that in these micropreemies, if you are intubating them and they do need surfactant, the earlier that you give them the surfactant, the lower the likelihood of BPD. So even though surfactant initially doesn't necessarily prevent BPD, if you've established that the baby needs it, the sooner that you give it, the better it is in protecting you from getting BPD. So what will be interesting in the future is what do we do with those group of babies that don't necessarily qualify for surfactant administration? So say you've got a 26-weeker with a grainy x-ray on CPAP, but is on FiO2 of like 30% and has a CO2 of, let's say, 61. So not a slam dunk, you have to intubate and give surfactant to this baby. But now, as you all know, we are giving surfactant in a less invasive way, or the acronym for that is Less Invasive Surfactant Administration, or LISA. LISA on paper has two advantages, and the first one is that you're not actually intubating the baby, you're just putting a little catheter through the vocal cords, and so that's the first advantage, that there's less likelihood of like irritating the vocal cords. The second advantage is that you basically just push the surfactant down a syringe and you're just squirting it down that tube into the lungs. You're not bagging it after you intubate the baby. So because you're not bagging it, which is associated with positive pressure ventilation injury, you are not creating any barotrauma. So there's kind of a hope that the LISA will be less invasive and will be less traumatic for the infants and hopefully translate to a lower incidence of BPD. So the question as we go into the future will be, are we going to lower the threshold for giving these babies surfactant because we're less concerned about any damage that the actual administration will give? The second way to decrease injury to the lungs is by preventing high oxygen exposure to the lungs. So anybody that's been in neonatology for the last 10 or 20 years will have followed the very interesting debate that we've had about ideal oxygen saturations in neonates. It's been known for some time that shooting for high oxygen saturation, so basically the baby satting at 100% the whole time, can increase the risk of BPD as well as ROP. But we weren't really sure what sort of ideal oxygen saturations we should be targeting. Two large studies were published, the BOOST trial as well as the SUPPORT trial, which basically compared lower saturation targets versus slightly higher saturation targets. And interestingly, or kind of expectedly, the trials found that even though the lower oxygen saturation parameters resulted in lower ROP and BPD, they were also associated with increased mortality, so increased deaths, as well as to a certain extent worsen neurological outcomes. So now we're not really sure exactly where we should be keeping saturations. Probably not always in the 80s. We don't want them constantly staying at 85%, and we definitely don't want them staying at 99 to 100%. Probably somewhere between 90 and 95%, or 90 and 94% is kind of ideal. A lot of units have their alarm set between 88 and 95 or 96%. And the third way of decreasing injury to the lungs is by preventing inflammation. So I'm not going to spend a long time on this, just for you to all realize that the more inflammation that the lungs go through, the higher the chance of developing BPD and bad BPD. So if the infant was exposed to chorioamnionitis prenatally, that increases the risk of BPD. If the infant has sepsis or pneumonia or necrotizing enterocolitis, or even has to go through surgeries, all of those are associated with increased inflammation and will increase the incidence of BPD. So whatever you can do to prevent all of those would be fantastic. As we always say, the smoother the course in the unit, the better the outcome in survival, in all morbidities really. And just as a reminder, the sooner you get that endotracheal tube out, the lower the risk of the infant getting pneumonia. So another great reason to try to get those babies extubated. In addition to preventing injury to the lungs, what else can we do to prevent BPD? Now we're going to go over the importance of giving good nutrition, of vitamin A, of caffeine, and then briefly we'll cover steroids, a very hot topic in neonatology. Let's start with good nutrition. As we talked about in the first video, ultimately to get babies off oxygen support, the babies have to grow larger, healthier lungs. So obviously, really good nutrition plays a really important role in preventing BPD. Numerous studies have supported this. One study showed that in infants who had received lower cumulative protein, carbohydrates, and fats in the first 14 days of life had a much higher incidence of BPD than infants that had received much better nutrition. Another study in a total of about 700 patients found that as the weight gain every day improved, the incidence of BPD also decreased. And interestingly, another study showed that in infants who were exclusively formula fed, and these were infants at less than 1,500 grams, they had an increased risk of developing BPD by about 2.5 times as compared to infants who were breastfed. So excellent nutrition is really important in preventing BPD. Early good nutrition with protein and fats and carbohydrates, and preferably breast milk, is really important, and good weight gain every day. Let's talk about vitamin A. So what is the importance of vitamin A? It has been known for a long time that vitamin A is important for lung growth, and it's important to keep the epithelial cells that line the respiratory tract functioning well. It's also been known that preterm infants that have a vitamin A deficiency at birth have an increased risk of developing BPD. So it was suggested that giving vitamin A exogenously, so you actually administer vitamin A, may decrease the incidence of BPD. And actually, a large meta-analysis found that when infants were given vitamin A over the course of several weeks soon after they were born, there was a slightly decreased incidence of BPD. But giving vitamin A kind of did fall out of favor, and most centers don't actually give vitamin A now. It's kind of a risk-benefit analysis. The first reason why we don't routinely give vitamin A now is that the follow-up studies at 18 to 22 months showed that in infants given vitamin A versus those that weren't, there wasn't like a significant change in neurodevelopmental outcomes. And the second one is the way that we give the vitamin A. Basically, it's an intramuscular injection, and it's given kind of 3-4 times a week for about 4 weeks. All the studies had kind of slightly different dosages. So it's not a completely painless procedure to give to a tiny baby that hardly has any muscles at all. And knowing that it isn't probably going to improve neurodevelopmental outcomes made the whole process of giving vitamin A just kind of fall out of favor. I think an important way to interpret this data is that we need to make sure that babies get excellent nutrition and get all their vitamins as soon as possible. Okay, what about caffeine? Caffeine is an absolutely fantastic drug, and I'm not just saying that because I love coffee so much. Black coffee with no cream or sugar, if anybody ever wants to bring me a coffee. But it is probably the most well-studied drug in the unit. Not only does caffeine decrease the incidence of apnea bradycardia, so it decreases the amount of events that an infant is having, it also has an anti-inflammatory effect. So it's actually also been shown to decrease the incidence of BPD. Caffeine should be started in all babies born at less than 30 weeks of gestation, and even in older babies if they have any respiratory issues. And really, the sooner you start the caffeine, definitely less than 3 days of life, the better it is for the babies. And normally we start with a bolus dose of 20 mg per kilo, and then we do a maintenance dose Q24 hours of 10 mg per kilo per day. The even better thing about caffeine is that many of the follow-up studies that were done on caffeine versus control infants showed that the infants that received caffeine, if anything, had slightly improved neurodevelopmental outcomes. As the babies got even older, kind of up to 10 years of age, some of these improvements kind of fell off. But still, we can feel pretty good that if anything, caffeine is better for developmental outcomes and is definitely not worse. Okay, now let's talk about steroids. We'll talk about it briefly here, and then I'll talk about it a little bit later in the treatment. And really, it's such a huge, hot topic in neonatology that really steroids probably deserve the video of their own. Especially since we all have such a love-hate relationship with steroids. So as you all know, steroids decrease inflammation, so it would be very logical to assume that since inflammation is such a huge part of the development of BPD, that giving steroids could therefore reduce BPD. And this is true. If steroids are given, generally they are associated with a reduced incidence of BPD. So in the 1980s and the 1990s, steroids were generally given for long courses and they were effectively found to reduce the incidence of BPD. But as more studies were published, it showed that the infants that had received the steroids had worse developmental outcomes than the infants that hadn't received steroids. They were shorter, the infants that had received steroids, they had smaller head circumferences, they had increased risk of cerebral palsy, and they had lower Bailey scores. So immediately everybody started panicking and thinking, okay, we should not be giving routine steroids at all to babies. And in fact, in 2002, the AAP, the American Academy of Pediatrics, came out with a policy statement and said we should not be giving routine steroids to premature infants. The problem is that now, since then, more and more infants, tiny infants, have been surviving, and BPD is still a huge issue. And we know that if a baby has really bad BPD, then that in itself is going to give really bad neurodevelopmental outcomes. So we would like to be able to use steroids to decrease the incidence of at least that severe BPD, whether it's to get a baby off the ventilator or just decrease the amount of oxygen that the baby's exposed to, or to kind of avoid a trach in an infant. And so different studies have kind of experimented with different courses of steroids to see what would be ideal to decrease the incidence of BPD, but hopefully not negatively impact developmental outcomes. And the AAP actually revised their statement in 2010, and they said that there may actually be a few babies, especially those born at like less than 1,500 grams and those that are still intubated at a week, that really may benefit from steroids, just because those babies were at such a high incidence of developing BPD, and BPD is really bad for developmental outcomes. For example, one of the studies done to kind of show that babies could get extubated and hopefully reduce BPD was the DART trial, which was dexamethasone A randomized trial, which showed that a 10-day course of dexamethasone could probably get babies extubated sooner and hopefully didn't really have bad neurodevelopmental outcomes. To kind of fully cover steroids, if you want to read more by yourself, then I would recommend 3 recent articles. The first one was published in the Journal of Perinatology in 2021, and it's an excellent review article of all the different steroids that are used in the prevention and treatment of BPD. The second article, and we've linked to all of these below, is a recent study published in the New England Journal that was a trial that compared giving infants 10 days of hydrocortisone versus not giving any steroids to those infants. And it found that the infants that had received hydrocortisone didn't really have a decreased incidence of BPD, but it also didn't affect their neurodevelopmental outcome. And the third study is another policy statement just published in Pediatrics by the AAP. And again, it just kind of goes over the recent evidence of steroids in the prevention and treatment of BPD. So all those links are below. I would highly encourage you to read through them. Altogether, what I want you to take from this is that babies should not be routinely receiving steroids. However, there are a select group of premature infants that may benefit from short courses, preferably low doses of steroids. The question is, we're not exactly still sure which steroids, which doses, and which babies. Okay, moving on to part 2, which is how do we treat BPD? So, like we said in the first video, the diagnosis of BPD is mostly a clinical one, and really we call it BPD when an infant is still needing oxygen at 36 weeks, corrected gestational age. So by definition, a lot of the treatment of BPD will probably be in the outpatient setting, but very often we can predict which babies are going to have BPD way before 36 weeks, so we're kind of already starting to treat babies in the NICU. So I'm briefly going to go over the different treatments that we use and what sort of evidence we have for them, which in a nutshell, not a lot of evidence. So the first big part of treatment is obviously giving the baby the oxygen support that they need. You don't want them to become acidotic because they lack the oxygen. So most of the time you're giving them the support, whether it's the nasal cannula or the CPAP or the ventilator, as well as the oxygen, the FiO2 that they need to keep the SATs really above about 90%. By the time the babies get older and that are higher risk of BPD, you generally want to keep the SATs a little bit higher, just because you're more worried about the development of pulmonary hypertension that can happen with lower oxygenation SATs. We really want the CO2s to be in the 40s or 50s or 60s. As you all know, we all practice a bit of permissive hypercapnia, which is where we allow the CO2s to go higher just because we don't want to beat up the lungs further trying to bring those CO2s down. So sometimes we'll even accept CO2s up to the 70s, just in a desperate attempt to get the babies off extra support so that we're not banging up their lungs even more. In the US, we will send babies home on oxygen. Generally, we send them home on pure oxygen, so it's 100% oxygen and it's not blended. And generally, we will send them home if they are on less than 0.5 liters. Ideally, and usually, honestly, we send them home at between 0.1 and 0.2 liters per minute. If we can't get a baby off positive pressure ventilation, then eventually a decision has to be made of how we can get this baby home. And one of the options is to insert a tracheostomy and send a baby home on positive pressure, whether it's CPAP or more commonly a ventilator. Obviously, this is not a decision that we take lightly. And so even after a baby had the tracheostomy placed, they're still in hospital for another 4 to 6 weeks after that, just with all the healing that needs to be done of the tracheostomy, as well as all the training that needs to be done for the family before they go home. So by definition, you're already adding another 1 month or 2 by making the decision to place the tracheostomy. So if you can get the baby to kind of home oxygen by then obviously the trach shouldn't be placed. Generally, we will move forward with a trach if the infants are about 44 weeks gestational age or above that and are really not making any improvements in their respiratory support. If they're making improvements, even if they're still on high vent support, then we will still try to push them forward. Out of all the preemies that are trached at birth or before discharge, they are generally have their trachs decannulated or removed by the time that they're about 3 years old. So it's still not a lifelong issue or not a lifelong operation that a infant with BPD would have, because as you all know, there's still a lot of lung growth in those first 3 years of life. The second thing that's very important in the treatment of these babies with BPD is that we provide excellent nutrition. So as we've said many times, if a baby has BPD, there's a high chance that they're breathing faster and breathing harder. So really, they need more calories just for that. On top of that, we don't want to fluid overload them because we don't want to make the lungs wet, which might make the BPD worse. So often we'll put these babies on higher calories, so like 26 or 28 or even 30 calories per ounce, and on lower volumes, so say 130 or 140 mLs per kilo per day, to try to maximize all the calories in their nutritional intake without fluid overloading them. Okay, what about inhaled steroids like budesonide or pulmicort or fluticasone? Again, there really isn't a lot of evidence to show that these help decrease the incidence of BPD or even necessarily treat or help BPD while babies are in the unit. However, as babies get older and leave the hospital, some studies have shown that these inhaled steroids may decrease some of the symptoms of BPD, like increased work of breathing or wheezing. And so generally, once the babies go home, they are pretty much put on the inhaled steroids. So we will kind of push that back. And if we think that the baby is needing a lot of oxygen support, then we will generally put babies on the inhaled steroids. It's not very evidence-based though. What about diuretics? Another really controversial topic. So even though diuretics like a furosemide or hydrochlorothiazide has been shown to improve lung compliance like over the short term, like especially if you have, like, as you all know, a really wet lung, you give a shot of Lasix, the baby pees it out and starts breathing easier. However, long-term diuretic use has not been shown to decrease the incidence of BPD or decrease the number of days that the infant is on oxygen. There was actually one recent study that showed that infants that had received more Lasix or furosemide after 7 days of life did have a slightly decreased incidence of BPD, and I'll put the link to that study below. What's even more concerning about this clear-cut data with diuretics is that, as you all know, diuretics also have a lot of bad side effects. So they can cause a lot of electrolyte abnormalities, so low sodium and low potassium and a metabolic alkalosis. They can leach out the bones and make the osteopenia worse. They can cause nephrocalcinosis as well. So again, despite not very overwhelmingly positive data and quite a few side effects, we often use diuretics in the unit, even if it's for short-term use, just to help with the fluid balance, especially if a baby does have a lingering PDA. It will be interesting to see where these studies land in the future. And then coming back to steroids for the treatment of BPD. Again, we're not really sure which steroids to use, and the two steroids that we generally talk about are dexamethasone, which is really a pure glucocorticoid, and that's thought to kind of like affect the lungs a lot more, or hydrocortisone, which is a glucocorticoid and a mineral corticoid. So that will kind of help with blood pressures as well as like with a direct effect on the lungs. So we're not really sure which steroids to use, we're not really sure which doses to use, and we're not really sure how long to use them for. As the babies get older, then we're more likely to use a prednisone as well. So as we practice now, generally, many of the units in America, if the babies are really, really young, especially if they've got blood pressure issues, they're more likely to use the hydrocortisone. If we're trying to get babies off the ventilator and they're not really having blood pressure issues or anything else, then we're more likely to use the dexamethasone. And if the babies are on like 2 liters high flow nasal cannula and we're trying to get them to home oxygen, or they're still on the CPAP and we're trying to get them off that, then we're much more likely to use like a prednisolone. So again, hopefully we'll have more information in the future about exactly which steroids and how much to use. Right, so part 3, let's talk about long-term outcomes of infants with BPD. And as usual, as you all know, this is really what we care the most about in the NICU. We want normal, healthy babies at home. So obviously the first thing is these babies have respiratory symptoms. Even after they get off oxygen, they're more likely to have tachypnea, breathing fast, increased work of breathing. They're more likely to have wheezing and shortness of breath. They're a higher tendency to get infections, especially pneumonias, and they're also at a much higher likelihood of being readmitted to the hospital because of getting that infection. So if an infant gets a cold, if an infant with a BPD gets a cold, they're much more likely to end up in hospital because their lungs are weaker. And in fact, infants with BPD have about a 50% readmission rate to the hospital within that first year of life. Generally though, as infants with BPD get older and their lungs grow, then the symptoms kind of go down. But in the longest study that's been done, the kind of longest follow-up study that's been done so far, about 25% of adolescents and young adults with BPD still had symptoms of BPD. So they still had increased wheezing and increased coughing and increased usage of medications as compared to adults who never had BPD. School children with a history of BPD also have been shown to have decreased exercise tolerance and decreased aerobic capacity. As you all know, with bad BPD, you can also end up with pulmonary hypertension. So the right side of the heart pumps to the lungs. And when you have higher pressures in the lungs, that right side of the heart can get tired or can get hypertrophied, and the pressure on the right side can also go up. This is kind of a right-sided heart failure or cor pulmonale. In fact, in about 50% of children who had BPD when they were infants, they were found to still have electrocardiographic. So on their EKG, they were found to have some level of RVH as compared to children who'd never had BPD. So even though eventually the heart gets remodeled and hopefully eventually these pressures go away, it takes many, many years for all the changes to actually occur. But just to emphasize, most patients that had a history of BPD, especially mild BPD, can go on to lead completely healthy lives. And even if they don't have excellent exercise tolerance, they can still exercise and perform all the duties that would require an excellent quality of life. What we do need to be worried about moving forward is how these infants with BPD are at increased risk for pulmonary complications later in their lives. Are they at increased risk for chronic obstructive lung disease, for example, like adult versions of lung disease? And so these infants should really go out of their way to protect their lungs as much as possible. These kids should categorically not be smoking or be exposed to secondhand smoke. Also, they should, as much as possible, be immunized. They should receive all their immunizations against the really scary, like lung infections, pneumonia, and whooping cough, as well as when they're young, even RSV or respiratory syncytial virus. Our second concern or concerning outcome is growth failure. It's not a huge step to think that because we're so worried about fluid overloading these babies and because they have such high metabolic demands that they may not be growing as effectively in length or as weight as babies without BPD. And in fact, especially earlier studies have shown that infants with BPD were not as tall or had a higher incidence of failure to thrive as compared to infants without BPD. However, I will say that a lot of those studies were published earlier in the thousands and in the 90s, and now probably because we know the importance of nutrition, it is thought that maybe the differences in weight are not so much to do with BPD, but the fact that they were smaller babies in the first place. And then probably the most important outcome is the neurodevelopmental outcome. So like we've said throughout this talk and through many of the other videos, the worse the inflammatory process, the worse the developmental outcome. And this has been shown to be the same in BPD as well. And it has been consistently shown that infants with BPD perform worse at every age as compared to infants without BPD. And by the infants being about 3 years old, about 20% of them will score less than 70 in cognitive and mental standard scoring tests. So really, anything that we can do to prevent BPD would be extremely beneficial. Well, that was a lot of information. You all did ask for it though. Go check out the links below. And in the meantime, please like this video and hopefully you'll subscribe to this channel. Thank you so much for being here.